All right, Delegate Kelly, the meeting's now live.
Wonderful. Great. Thank you so much. Hello, welcome to the Joint Committee on Children, Youth, and Families, our second meeting of the interim. I'm Delegate Ariana Kelly. I'm the House co-chair. I'm proud to be joined by our Senate co-chair, Mary Washington, who will give some introductory remarks just after me. This month's meeting, we're focusing on long-term care, and next month's meeting, we'll be discussing childcare. So next month's meeting, just so everybody has it, is on November 5th. This month's meeting agenda, we were going to be discussing recommendations from the Oversight Committee on the quality of care in nursing homes and assisted living. One of our goals with this joint committee is not to be duplicative. So if there's other groups that are doing work, to keep our members informed on that work, but not recreate the wheel when it's happening somewhere else. Unfortunately, we got the timing a little bit off and those recommendations aren't ready yet. I think Senator Eckert, are you on that Oversight Committee? Yeah, okay. So we do have some cross-pollination with members, and a number of the speakers today have been participating in that work. So we'll get a little bit of a sense of what that work is looking like, and when those recommendations are final, we'll make sure to distribute that to the members of this joint committee, but they're not ready as of yet. But we are going to have an overview of long-term services and supports report card in Maryland from AARP. We're going to discuss recent trends and challenges in long-term care, and we're going to have update on services for developmentally disabled individuals. So we do still have a lot to talk about this month, and I thank everyone for joining us. I think it would be great, Senator Washington did this last month, I thought it worked well, just to have every committee member check in and say hi, introduce themselves so that we know who all is on the meeting. So I guess I'll start with the House side. I see Delegate Ebersol is here. I'm going to say hi.
Hello, Delegate Ebersol representing District 12, Baltimore and Howard counties.
And Delegate Krebs is also here.
Hi, Delegate Krebs from Carroll County, beautiful Carroll County.
Wonderful. And Delegate Atterbury, I believe, is on the line with us.
Yes, hi, Delegate Atterbury from District 13 in Howard County, and I'm multitasking at the minute, which is why I'm not showing my face.
Which reminds me, the first thing I was going to mention is I'm also multitasking here in a lovely residence inn. I had a flood in my house, so I have 4 children homeschooling along with my dog here. So forgive me if it gets a little chaotic. I will hope that it is not. Senator Washington, do you want to have some opening remarks and then introduce the Senate members that are here?
Oh, great. Hello. Just great to see everyone. I'm going to try not to multitask. I don't have an excuse. So you will get my full attention. But I'd like to recognize, Delegate Mary Washington, I represent the 43rd. Oh, Senator Mary Washington, I represent the 43rd District. It's being around all of you folks. Brought me back to old school days. This is good. This is going to be a great meeting. This is an issue that the delegate and I have really been very, very interested in for a lot of reasons. And then also we frankly believe it's an issue while there's a small core of people that have been dedicated to it over a decade or more than a decade, it's really the opportunity to really raise it up as an issue for both of our houses, and we'd really like to move forward in that. So we're joined today by our Senate President Pro Tem.
Good morning, I'm Melanie Griffith. I represent Central and Southern Prince George's County, otherwise known as District 25, and I chair the Budget and Tax Subcommittee on Health and Human Services, which has jurisdiction over a lot of the subject matter for today. And I think every member of the Senate who's on this Zoom, Madam Chairs, every Senate member was a member of the House, if I'm not mistaken. So I feel like I'm in good company.
Actually, Senator Addie Eckert.
Senator Addie Eckert from beautiful downtown Cambridge, the marina on the other side of our condo building, and I represent District 37, Dorchester, Talbot, Caroline, and Wicomico counties. I'm a member of Budget and Tax with my colleagues, and also I'm very interested in the topics that we cover. The life cycle is what we're doing. We'll do kids and we'll do seniors, all very important during this pandemic. Thank you.
Thank you. And we have the senator who represents both Baltimore County and Baltimore City.
There we go. Good morning. Charles Sitnell, representing District 44, covering, as the senator mentioned, Baltimore City and Baltimore County.
And we have the good senator also from Baltimore County.
Hi, I'm Shelley Heddleman, District 11, Northwest Baltimore County, right near Senator Sidner's district. Glad to be here. Thank you.
Okay, that's it. Thank you.
Great. Well, thank you for the Senate introductions and for your remarks, Senator Washington. I think we might as well get started because we have a full agenda. So let's hear first from the panel from AARP to discuss the services and supports scorecard. That's Susan Reinhardt and Ari Hauser. Well, Ari's here.
Sorry, Delegate. We missed. I missed the Senator Benson is here. Sorry.
Wonderful.
Senator.
Welcome. Introduce yourself, please.
Hi. Good morning. Joanne C. Benson, 24th Legislative District, Senator. Woo, glad to be here.
Glad you're
Happy
here.
to have you. All right, so let's hear from our first panel, which is Susan Reinhardt and Ari Hauser.
Great. So Ari, are you managing the PowerPoints or someone else?
I'll be managing the PowerPoint. Let me bring it up really quickly.
Okay. So while you're doing that, I wanted to thank you for this opportunity and tell you that my son is moving to Bethesda like this month. My husband is there right now helping them paint the house. So I'll be spending a lot of time in Maryland. And also that the fact that you're in the top quartile of the country in terms of states that are trying to reach a high performing state system for long-term care.
Where's my screen?
Is one of the reasons you're there is because you have meetings like this to say, okay, we're doing pretty good, but how do we get better? So I just want to acknowledge that this is a really great opportunity. So I'm Susan Reinhardt. I am a Senior Vice President at AARP. I direct the Public Policy Institute, which is the think tank of AARP. And with me is Ari Hauser, who is our Chief Statistician. And together with the team, we have been creating these scorecards. This is the fourth scorecard. The first one was in 2011. So let me, what we're gonna do is I'm gonna give a very brief overview to just set a context, and Ari's gonna go deeper into the Maryland data, which we hope will spark conversations. And I think we have about 15 minutes. So we are gonna be very good with our time. Next slide, please. You have these slides, I think, ahead of time too, as well as the scorecard. So the next one. And we also gave you your fact sheet for Maryland. So I think you have a lot. So I'm not going to read all of this. This is really more for your background, but just to say what the scorecard is, this is a compilation of state data. As I said, we've been doing this for now more than a decade. It is multidimensional across 5 domains that I'll say more about in a moment. But the purpose of this is to stimulate dialogue and to prompt action, as I said. So it is state level data. We do have national comparison data, but this is really comparing states so that first you can figure out what you want to talk about. If you go to the goals here, to assess your state, to measure progress, because we can measure progress over time for most, although not all of the indicators. And to really focus in. I mean, there are 26 indicators here, so I know you can't really look at every single one of them. So what is it you want to focus? And the other thing we like to point out is that this is not only about the public sector, but the private sector as well. But there's a lot, of course, in public policy. And I also want to say this is about older adults, adults with disabilities, and family caregivers. It does not address developmental disabilities or children. So those are the populations contained in here. And the data were collected by the end of 2019. So all of this is pre-COVID, but we think it's just as relevant today. It does not address nursing home COVID issues. It didn't before, it doesn't have infection data, et cetera, but it is more about home and community-based services. Next slide, please. There's a lot on here. I'm not going to go through it, just for you to have it. These are the 5 dimensions. We have a vision that was created with a National Advisory Committee a number of years ago that has 5 dimensions. What is the ideal of a long-term services and support system, like nirvana, I like to say. And we have these 5 dimensions. So affordability and access means ideally everybody could afford long-term services and supports and they could find them easily. That would be the ideal. And within that, There's the cost of different options. There's a bit about Medicaid access and aging and disability resource centers. How do you find those options? The second dimension is having choices. So how can you make it possible that people don't have the only option, a nursing home option or an institutional options? So it does look at Medicaid spending and users. Is there a balance in how Medicaid funding is being dedicated for options? Self-direction, meaning that people can hire their own workers, so to speak. And Ari will say more about that in a minute. And about supply of home health, assisted living, adult day, and housing. So we're not only looking at nursing homes or assisted living, but housing, which is where people really want to live. Quality of life and quality of care has always been a problem in terms of measures from the very beginning. We have nursing home measures. We have them in there, like nursing home inappropriate antipsychotic use, pressure sores. In the past, we've had restraints. There's lots of nursing home data that does not include infection rates because we didn't include it. It really wasn't very good data, frankly, to begin with. But the other issue is home and community-based services. There's been really not a great, actually almost no data on home and community-based services quality across the country. So your state no doubt has measures that you're using, but they are not necessarily comparable to the rest of the country. And support for family caregivers. This is a policy area. We have about 12 different policies that are grouped into these 4 areas: supporting working family caregivers, person and family-centered care. We'll hear more about that from Ari, where you fit into this. But this dimension is incredibly important. It's equal. All of these dimensions are equal in weighting. So it's just as important as quality, affordability, choice, and the last one is effective transitions. And the goal here in a very high-performing system is people don't get bounced around. They don't, they're not stuck in a nursing home. If they have low care needs, they should be able to be served in the community, ideally, if that's their choice. And they don't go from a home health admission back to the hospital, nursing home to a hospital, et cetera. So next slide. I know that's quick, but here's some high-level findings. So what we find is that states have made modest progress, but not enough. And so what it says here is there's 21 out of 26 indicators where we can measure change over time. There's only 6 of those indicators where there was any significant change. 5 indicators showed significant improvement and 1 showed significant decline. And on the right side, that's where they are. So significant, more than 20 states improved significantly in finding things, the Aging and Disability Resource Center being able to find different choices, their balance of Medicaid spending on long-term care, on home care versus nursing home care, nursing home antipsychotic use has improved, and then support for family caregivers has improved quite a bit, both in 2 dimensions that you'll hear more about in a moment. And 20 states declined in long-term care insurance. Next slide. So here's the overall rankings, and you can see that Maryland, the orange is the highest, the top quartile, and the bottom is the very dark, and in between or in between. Maryland does fit within the first quartile. You'll see that it's sort of on the East Coast and the West Coast, a little bit with Minnesota, for example, and the Florida, the southern, eastern part of the country has the most challenges, I'll say that, but the South in general has the most challenges. Next slide. So I did that very rapidly because what you're going to hear now from Ari is more about your findings, which I think is what you really want to hear. So Ari.
Thank you, Susan. I was going to talk briefly about the scorecard findings for Maryland. I do have a personal interest in Maryland. I'm a Maryland resident. From August through December of last year, I lived in the Residence Inn in Bethesda on account of a flood. So Delegate Kelly, I can only imagine not getting to leave to go to work every day. Also, probably more relevant to the scorecard, my parents-in-law are Maryland residents and are in their mid-70s and are very likely to be consumers of long-term services and supports in the next decade or so. So you can go next slide. One of the main audiences for the scorecard are state policymakers, legislatures, advocates. And so within the scorecard suite of products, we have a 2-page fact sheet for every state. You should have gotten the Maryland fact sheet as an attachment. If not, or if you want to distribute it, the link to is here on the slide. This puts this fact sheet's a 1-page overview of what the scorecard is, and then all of each state's data, including not only the indicator values, also any trend data, the US average, and the highest performing state, so that you can look at your state and see how it fits relative to the other states in the country. Next slide, please. Just to briefly overview Maryland's data, Maryland is in the top quartile of performance, but like almost all states, even those in the top and bottom tiers of performance, the LTSS system has areas of strength and areas of relatively low performance relative to other states, which we like to call the opportunities for improvement. In the 5 dimensions of performance, Maryland is in the top quartile or very close in 3 dimensions. So these are Maryland's strengths: affordability and access, support for family caregivers, and effective transitions. In the 2 other dimensions of performance, Maryland is really in the middle of the pack, in the 3rd quartile, just below the median, national median. That's the choice of setting and provider, quality of life, and quality of care. One additional strength that Maryland has is that over the 3 years since the last scorecard, the state improved meaningfully in 8 indicators out of 21 where we can show change over time, and declined in performance in 0. And of all the 50 states in DC, only New York attained that level of improvement. When I say over the last 3 years, that's over the last 3 years of data. So this is change that's could be going back 6 years. So in the last 6 years, Maryland has made a lot of improvements to the LTSS system. Next slide. Looking overall at Maryland's data and taking into account not just the level of performance, but also how amenable these measures are to action. The scorecard is really a consumer focus. It looks at the performance of the LTSS system from the point of view of an LTSS user or their family caregiver. And not every aspect of performance is something that's easily addressed by state policy, but some are, and these are 2 broad areas that really stand out. The first is the balance of long-term services and supports toward HCBS, home and community-based services. Mostly services in the home, also in the community in a non-institutional setting. People overwhelmingly prefer to receive services in their home or in their community. Maryland has made some improvements, but is still below the national average in the percentage of spending going to home and community-based services, and in the percentage of people who are receiving long-term services and supports in the community. In particular, self-direction, and that's where people, instead of being assigned a service provider to come to their home and provide them the services they need, are given some choice in who provides those services, how those workers are paid. It's not a new type of service. It's really people being given more control over the services that they have been authorized and are receiving. Is virtually non-existent in Maryland. The national average is about 30 people self-directing their services per 1,000 people in the state with disabilities. The highest performing state, 150 people per 1,000 people with disabilities. In Maryland, it's less than 2, about 1 in 600 people with disabilities is self-directing services. And this is something that's particularly important in the time of COVID. People are safer when they're not in congregate settings. They're safer when they have control over who enters their home. These can be workers, can be perhaps family members or neighbors, some people that they already know, that they're comfortable with, that they may already be having exposures to. It's just another reason that self-direction and home and community-based services are particularly important at this time. The other big area of improvement is policies to support family caregivers. And recall, this was one of Maryland's strengths, and it is, but there are a lot of things that can still be done. In the area of supporting working caregivers, we identify 6 different policy areas. In 2 of those 6, Maryland is among the leading states in terms of providing support for working caregivers, but there's a lot more that can be done. I know that there is that our Maryland AARP office is supporting legislation in the next session that is proposing paid family leave, something that is critically important for family caregivers so that they can continue to help people with disabilities when those challenges become particularly intense. And again, in the current time when during COVID, family caregivers are doing so much more than they have, and this is especially important. The other area for improvement is in person and family-centered care, and this is one area in which Maryland's performance lags. 2 policy areas, spousal impoverishment protections and caregiver assessment, are supports for family caregivers in their role as caregivers, where some policies could be implemented to really help caregivers out. Next slide, please. That was a quick overview. There's a lot more information on the longtermscorecard.org website, and Susan and I are here if you have any questions.
Wonderful. I do have actually 2 questions, and then I'd love to hear questions from the committee, and also give Senator King a chance to introduce herself because she has joined us, but she missed the introductions. So first, before I give Senator King a chance to say hi, let me ask my 2 questions before I forget. One is, I think, an easy question for you to answer, and one is a harder question that I've been struggling with, and I think particularly our colleagues who are here on the budget committees may be able to help get a big picture around. The first question is the metric that you were using for quality of life, where Maryland is, in that 3rd quartile. What does that actually mean? What were you using to determine how people were experiencing quality of life?
Go ahead, Aaron.
As Susan mentioned, the quality of life and quality of care dimension is the one that's really the most challenging for us to get good state level data. We're measuring that with 4 indicators. One is the employment rate for people with disabilities of working age. There's 2 measures of nursing home quality. The percentage of high-risk residents with pressure sores, and the potentially inappropriate use of antipsychotic medications for someone that doesn't have a psychiatric diagnosis. And the last is not a measure of home and community-based services quality, but a measure of what tools the state's using that will allow them to benchmark their HCBS quality against other states. We know all states are measuring HCBS quality, but they're all doing it differently in such a way that we can't really compare across states at this time.
Okay, so employment rate, pressure sores, antipsychotic use, and some sort of home and community-based services quality measure.
Yeah.
So that sort of brings me to my next question, which is ranking 43rd in spending on home and community-based services. Is there something that Maryland's not doing that other states are doing? How would we be so low? And that maybe is not a question that you guys can answer, but that's sort of the big picture question that, at least on the Health and Government Operations Committee, I chair the long-term care subcommittee, and that's certainly a question we've been struggling with. So I don't know if you have anything to point us to.
Well, I'll start and then I'll turn to Ari. There's actually these two indicators. One is the spending balance and the other is the users. And so obviously the more cost per person affects the users also. So you're actually 34th in spending and 43rd in the use, just to point that out. So there's two ways of looking at it. And it means that you're spending more money, Medicaid and state funding, I guess you would say, for nursing home care. So there are lots of ways and strategies, and we've actually looked at promising practices, and this gets into diverting. It's called diverting. How do you help people not enter a nursing home to begin with if they don't want to? We recognize this is a choice, but how can you do that? Is your Medicaid eligibility process okay? Or is it that it takes so long? And I don't know this, it's possible that it takes so long that really they can't go into a home base. So you can't get people coming into the home because Medicaid won't pay for it. So they go into a nursing home because nursing homes have the cash flow typically to carry you until your Medicaid eligibility is established. And that goes back to when you first applied. So nursing homes handle that routinely across the country. So that limits the ability of the state to really help people go in one direction. You can do things like presumptive eligibility. You can do it very quickly. You can see if somebody is likely going to be eligible for Medicaid. There are a couple of states, I'd say maybe 8 or 9 that are doing that now. And it's really something we're going to be promoting quite a bit.
Great, thank you for that. So Senator King, did you want to just say hi and introduce yourself? And then I know we have a question from Delegate Ebersol.
Good morning. Just coming in on the kind of the end of this conversation, you know, many of you know, I spent many years at home taking care of my husband who had Alzheimer's and then moved him to a nursing home for 3.5 years. So I have lots of stories to tell, and believe me, I've been there and done that. So interesting conversation.
Wonderful. And as I understand, Delegate Rose is also on the line. Did you want to say hi? She might not be on the line yet. Thank you, Senator King. Let's hear Delegate Ebersol's question.
Thanks, and happy day after birthday, Senator.
Oh, thank you. I don't look a day older, do I?
No, not even a little bit. I would have never guessed it was your birthday. Ari, thank you for that presentation. The materials we have are something that, here, I'm going to get it's just something called Advancing Action, which doesn't have the Maryland, the specific overview for Maryland. And you quickly flashed it up on the screen, but there's no way to copy and paste it in there from your presentation. I wonder if you could put into the chat link so that I could look at that overview and scroll back and forth on a little bit as we go, because I don't believe I have that at my fingertips here. I've tried looking at all the attachments in the mail. I have a 104-page document, which is full of good stuff.
Oh yeah, no, we call that death reference.
Right, and it puts us in our place each and every possible category. But I would like the overview would be helpful for some thinking points.
Right, we definitely wanted you to have that. Did others not receive that?
I was looking for it too, Delegate Ebersol, and I didn't find it either. So let's.
What relief! I was hoping it wasn't my technical.
I'll put that in the chat.
So glad. I'm so glad.
Yeah, if you could put the link in the chat, Ari, I'd appreciate that. Thank you.
Can you do that, Ari? He's saying yes.
Yes, it'd be a 2 or 3 minutes.
Okay.
Yeah, no worries. So I don't have a real question. Sorry, I can't.
No, that was a great question.
Kelly's expertise and incisiveness there.
We do have a question from Senator Benson, I believe.
Yes, good morning.
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 I think you went on mute.
There you go.
I heard you say that there was a need for legislation. Could you go back and talk to us about what kind of legislation is needed?
I think, Ari, that's what you mentioned about the, I think you call it the Family Medical Leave Insurance Program. Is that the one you were mentioning? That
yes, that's the one.
Yeah, so that has been proposed. I know that Maryland ARP supports it. And I don't have a lot of details about it. Maybe you do, Ari, or maybe somebody is the sponsor of it in this group.
I think in the Senate, it is Senator Hayes, and in the House, it's Delegate Valderrama. I do know the bill is coming back again this year. It did not have a vote last year, but I know that there's a growing campaign to support the bill in Maryland this year.
Here's what I've been told, that it would make paid leave available to Maryland workers for up to 12 weeks following the birth or adoption of the child, and when needed to provide care for a family member or oneself. And the leave would be funded through an insurance pool into which workers and their employees contribute.
Okay.
No personal knowledge. That's the summary that I have.
Okay, so that's coming back.
Yes.
Okay, thank you. That's what I was interested in knowing.
That would be a tremendous help, tremendous.
And it's going to be sponsored by Senator Hayes.
Yeah, Senator Hayes and Delegate Valderrama had it last year. I believe they're sponsoring.
Yeah, that'll come before my committee. Okay.
Yeah, and your committee, I don't think they voted on it last year, but I do think that there's an intention to move something, hopefully.
Okay, thank you.
Any more questions?
Yeah,
Okay.
Chairwoman, this is just a question about insurance, and maybe it's staff and maybe it's a research question. Maybe Ari knows this, but long-term care insurance. I mean, I know it's something that's not offered. I do know that this, I thought the state of Maryland offered it to its employees at some point. Do we no longer do that? Is that is offered? Does anyone know, or I'll just put it as a question. Does the state offer long-term care? Did we used to offer long-term care insurance? And if we don't, we need to check it out. Okay, so no one knows offhand. Okay.
I don't know that the state offers it to employees. I do know this is something that HGO has looked at in terms of, really that marketplace has been falling apart. And a lot of companies faced a lot of challenges because the actuarial tables didn't work that well. So rates have been skyrocketing. Consumers have been really hurt by that. So it's something that we have been looking at, but in terms of state employees alone, I'm not sure. I don't think we do now. I don't know that we did in the past. It's generally a private pay product from what I understand.
Mm-hmm. Okay, can we check that? Because I think we used to offer it and we stopped a few years ago. So, okay, thank you.
I just want to mention that self-direction again, when you said, what else can I do? So that is, it's used very widely on the West Coast in California, in Washington, and in other states. It really is significant. You usually need to do this through some kind of amendment to your waivers or for a personal care state plan amendment you have. And it allows a person to hire, say, their daughter, their granddaughter, their neighbor, who then still has to, according to your own policies, has to go a criminal background check and some kind of training. It's totally up to the state what they do there. But this has been incredibly important to states that have been able to balance more, I'll put it that way. And Ari's point is during COVID, we're actually going to have another paper coming out. This has been, the state of Washington reported this about 2 weeks ago. This has been incredible to be able to hire someone you know and trust sort of in your pod, to say, rather than strangers coming in and out that people, first of all, don't always feel comfortable with. And secondly, now are really, really worried about. So I encourage and would be happy to give you more information if that's something you're interested in. But it is something you can do. It should not be increasing the cost of your Medicaid program. It's a way of delivering services.
Wonderful. Thank you for that. Any more questions for this panel before we move on? Thank you so much. This was really informative. I do see a question from Delegate Ebersol in the chat, just specifically looking for a link to the summary that was presented. So hopefully we can get that link also shared in the chat. And I know we'll be reviewing all of this information. Senator Hedelman has one more question. Thank you.
Thank you. I wonder if you have any of this data broken down by communities, different communities. I know, we have seen learned so much about the disparities in healthcare, certainly through COVID. And so I imagine those carry on to who avails themselves or who can have access to different types of care. So I'm just wondering if you have any of that broken down.
We don't in the scorecard. This is state level data. We have a livability index that goes by census tract data, which doesn't get into long-term care, but it does get into housing. It gets into some aspects of it, and we can give you that information. We are also going to be releasing a nursing home COVID-19 dashboard next week, actually, a week from today, which again is state level. It's being aggregated to the state level, but CMS, Centers for Medicare and Medicaid Services, does have that data by nursing home level, by facility level. We've just aggregated it up to a state level. So you can look at that if you're particularly interested in nursing homes.
Wonderful. Thank you. Well, thank you very much for this very informative presentation. And we will move on now to the Alzheimer's Association. Eric, oh gosh, Colchamiro. Did I say it right, Eric? I get it wrong every time.
You did great.
Hi, thank you.
Thank you so much. Go ahead, Eric.
Chairwoman Kelly and Washington, thank you for the opportunity to brief the committee. As Chair Kelly mentioned, my name is Eric Colchamiro, and I'm the Director of Government Affairs for the Alzheimer's Association in Maryland. For those of you who may not be aware, the association and our 2 chapters which serve Marylanders is the leading voluntary health organization in Alzheimer's care, support, and research. Our programs and services include a 24/7 helpline, caregiver support groups, and an early stage memory support group for people with Alzheimer's or related dementia. All of these programs are free to Marylanders, and all of these programs are happening remotely during this pandemic. Thank you for the opportunity to discuss the long-term care industry and its impact on families during this unprecedented time. I want to say from the onset, the 3 provider groups which represent this industry in Maryland are partners of the association. Well over 40% of their members' residents have Alzheimer's or some other form of dementia. And during this pandemic, we were actually also pleased to host the 3 industry executives for a webinar where we provided them a platform to discuss their COVID-19 response. Yet when I consider the response of industry, along with that of the Hogan administration, when I consider that as of yesterday's health department data, roughly 56% of Maryland's COVID-19 deaths have occurred in long-term care facilities, I believe we can all do better for Maryland's families. The impact of the virus on long-term care facilities is understandable from a biological standpoint, as COVID mercilessly attacks those with pre-existing conditions in many older Marylanders. Yet from an operational standpoint, families lost loved ones during this unprecedented time, also because infection control procedures were not consistently followed at long-term care facilities. We know that at least 64 nursing homes received fines from the state for not following inspection control protocol. 10 of those fines ranged from $70,000 to $380,000. The other 54 were ordered to develop practices to fix the problems. Additionally, 45 facilities received smaller fines for not completing mandatory testing and reporting to the state. For assisted living facilities, unfortunately, we don't have a full picture of their efforts. There are over 1,500 assisted living facilities in Maryland, and the health department's COVID-19 testing mandate only covered those with 50 or more beds, which is less than 9% of them. Underlying these operational concerns directly at facilities is the Hogan administration's role in supporting, communicating, and overseeing what happens there. When families put their loved ones in a long-term care facility, they're trusting the state to aid in making sure care happens well. To start, I think families have been challenged by the work of the health department's Division of Infectious Disease Epidemiology and Outbreak Response. It's a long title, but what that is the Bureau of the Health Department that oversees the COVID-19 website for the state. And I'll raise 3 issues, which I think have muddled the picture of this pandemic for families who have loved ones in long-term care facilities. First, the long-term care website only displays data from facilities that have had cases in the last 14 days. So, for example, for someone relocating to Charles County, if you looked yesterday at a long-term care facility to place your dad, you would be hard-pressed to see any information about the numerous cases at Sage Point, which was fined $380,000 by the state. 2, the long-term care facility section of the website is updated once a week, despite information regularly flowing into CRISP. So if I'm checking about facility information for my dad on a Tuesday, There's no publicly available data there about outbreaks in the last 6 days. And 3, if the website only includes data about assisted living facilities with 10 or more beds, which misses, according to industry representatives, the supermajority of locations. In short, for families seeking to place their loved ones in a Maryland long-term care facility, it's really hard to find good information. Shifting to the Health Department's Office of Healthcare Quality, the most recent annual report from OHCQ showed a roughly 13% deficit of nursing home surveyors and a 5-person deficit of assisted living surveyors for this bureau, which enforces healthcare quality at long-term care facilities. I'm pleased that they have instituted a 5-year staffing plan to hopefully address this, but I'm also concerned, especially during the time of this pandemic, that for nursing homes in the last fiscal year, inspectors completed surveys and follow-ups at just 194 of Maryland's 227 nursing homes in the last fiscal year. And they have inspected on average just 56% of all assisted living facilities in each of the last 3 years. All told, we, and I emphasize we, can do better in helping protect Maryland seniors and aid their families in making decisions about long-term care. Shifting to personnel issues, one thing I want to emphasize overall, big picture, is that this pandemic has created some new concerns at long-term care facilities, but it has really also heightened existing ones. And while I certainly have critiques of the administration's response, they did lead well back in early April to create strike and bridge teams to help facilities in need of support for infection control and staffing. They should be commended for that, as it saved lives. I want to focus my personnel remarks on one key issue, and that's workforce recruitment and retention. We're concerned, especially during this pandemic, about the recruitment and retention of the long-term care workforce. Many of the individuals who work at these facilities are heroes. Yet, recent studies have shown that nursing homes employ large portions of their population at the minimum wage. These workers are, in short, dealing with complicated medical situations during a pandemic and receiving very low wages. I am pleased that while not addressing the wage issue, the health department has partnered with the Maryland Institute for Emergency Medical Services Systems to provide a free COVID-19 mental health crisis support program for staff. Yet I also know that this program has had a minimal uptake. The last report I heard, staff at just 30% of long-term care facilities had availed themselves of it. And big picture, when we consider the health of families during this time, we must recognize not only the individuals who are and their loved ones who are at and residents at long-term care facilities, but also the staff at the facilities and the impact this pandemic has had on their families. Next, visitation. A particular area of interest for families across Maryland is visiting their loved ones. There has been a series of health department guidance put out on this, but I want to focus on the most recent one, which said, in a nutshell, that 1, all previous guidance is revoked, and 2, facilities should follow CMS guidance. So what does CMS guidance say? It says a lot, but a real brief snapshot. Visitors should be screened for COVID-19 symptoms, but are not required to be tested, even if they go indoors. It says facilities can request proof of testing, but they cannot require it. And it says that the long-term care ombudsperson's office matters. Facilities must communicate their reopening plans with them, and consistent with late April guidance, the ombudsman's office must have immediate in-person access to any residents, including a review of their records, to act as an on-the-ground representative for their families. Let me be clear, the need for families to see their loved ones at long-term care facilities is real. The impact of social isolation is significant. Studies have shown that loneliness and social isolation can be as damaging to health as smoking 15 cigarettes a day, and perhaps even more so among seniors. Yet there is a need and no longer a clear mandate for consistent point of care testing to ensure the safety of facilities for our loved ones who live there and who work there. Please make no mistake, there is a significant cost to facilities of testing. And so I'm pleased that Governor Hogan, despite eliminating the weekly testing requirements, has announced that he will add to the over $100 million that he has provided to this industry in the state. And I hope that a significant portion of the 500,000 rapid tests, which the administration recently acquired through a multi-state compact, are distributed to and able to be used by Maryland's long-term care facilities. Yet despite all of this support, we are dismayed by the CMS guidance, as we expect many of Maryland's facilities to shift to a monthly testing protocol. The Alzheimer's Association supports long-term care regulations that not just comply with CMS guidance, but go a step further to protect residents and their families. Arizona, for example, requires indoor visitors to provide a negative COVID test that is less than 48 hours old, and also to sign an attestation that they have isolated between when the sample was taken and their visit. Testing once a month, however, when staff are coming in and out of facilities daily, puts everyone at risk. I've covered a lot of ground, and I want to close with a few potential policy recommendations in the words actually of one of our staff members from the association who has a personal connection with COVID and long-term care. Testing. The association remains tremendously concerned about the impacts of this pandemic on social isolation. We want to address social isolation, but we are dismayed about the lack of a consistent rapid turnaround testing protocol within CMS guidance to ensure safety. Quality. Families, especially during the time of a pandemic, when they have not been allowed inside, place an implicit trust in the state to inspect long-term care facilities and protect their loved ones. Yet, despite their statutory requirements, the state does not inspect all nursing homes annually and inspects far fewer assisted living facilities each year. Workforce. Families benefit from good, trained staff paid above the minimum wage, especially during a time of crisis. Industry will rightly, and I want to emphasize rightly, point to low Medicaid reimbursement rates. I urge the General Assembly to remain vigilant, particularly with the rising minimum wage in our state, to ensure that the mandated 4% Medicaid increase is implemented in a full and timely fashion. Yet along with Medicaid advocacy, we need to look deeply at our direct care workforce and consider how we can help them so that long-term care facilities can keep its quality staff. I'm glad Senator Griffith is on the call. I believe that legislation or even budget language can be enacted to study and consider a set of specific recommendations through the Department of Labor, through the Maryland Healthcare Commission, or a new independent commission, so we can understand and get better solutions about how the long-term care industry can best recruit and retain its workers. I hope workers can be empowered with personal information forms about each of their residents to provide person-centered care about all of their patients coming in. And I hope we realize that according to Lifespan, the turnover of the direct care workers in nursing homes is 100%. And as families try to navigate this pandemic, we must consider the families of individuals who live at long-term care facilities and the families and the individuals who work there. Data. As facilities try to make informed choices about long-term care, there are significant improvements that the health department can make this fall on how it displays data. Alternatively, legislation currently being developed in HGO around data reporting can incorporate what information and how frequently information is displayed about long-term care facilities. And lastly, social isolation. As I mentioned, this was an issue prior to the pandemic, and it has only been heightened. In-person visitations for facilities that are able to have it will help. Yet I would urge a concentrated investment, a budget appropriation, or amidst this time leveraging of existing agency resources to help seniors in need of connection. This could mean more widespread distribution of personal information forms I mentioned. It could also mean, like the Alzheimer's Association did, partnering with the state of Florida on what we call Project Vital, using federal funding to distribute tablets so residents can engage with their families virtually. Lastly, I want to leave you with some words from my colleague Julie, who has a mom in a nursing home in Maryland and recently wrote about the need to end senior isolation. She writes, "I'm one of the lucky ones. My mother is under hospice care, which allows me to visit on the inside after I am screened through the now standard COVID checkpoint. And she and I sit among the other residents who are void of visitors. I feel alien in their world. Over the week since Mother's Day, the first day I was allowed inside after weeks of window visits, I detect the decline in other residents. It's like a palpable curling inward of their very souls. My mother, on the other hand, seems to be recovering. Her regular contact with those who love and cherish her have made her stronger." I want to thank the long-term care industry for their work caring for Marylanders with Alzheimer's and dementia amidst a pandemic that none of us could have been fully prepared for. Thank you to the health department staff who has worked tirelessly, and thanks to all of you for the opportunity to share a few words. We're all in this together, and I think, as I've mentioned, I think we can all do better together.
Thank you. And before we have questions for Eric, let's hear from Dana Kaufman, and then we'll do questions for the panel at the same time. Dana?
Thank you, Chair Kelly and Chair Washington. My name is Dana Kaufman. I'm with the law firm of Schwartz, Metz & Wise, and I'm here on behalf of Lifespan Network, which is a senior care provider association. Part of my presentation is basically to give you a little bit of a time frame from when the pandemic began in March until now. There has been so many different changes in guidance, including the Maryland Department of Health guidance and CMS guidance. So I kind of just want to give you the broad picture of where we have been and where we are now, and then really where we need to go. But I do want to mention real quick one comment that was raised, and that was the deficiencies in the nursing home. So OHCQ did do an infection control survey for each nursing home, and there were 64 deficiencies, or 64 facilities, I should say, received deficiencies. But if you flip that around, that meant that 162 nursing homes in the state of Maryland were found to be in full compliance with infection control. And they should be applauded when you consider the global pandemic and the lack of information early on that was not provided or just not known simply, asymptomatic carriers and things along those lines. But even when you look at those 64, 10 received actual infection control deficiencies. 54 were on reporting issues. And for example, just to kind of paint that picture a little bit more, 32 of those deficiencies were for not reporting to CRISP on a daily basis. And it's very interesting, that number, because it was $250 fine for not reporting to CRISP. But I can say, because I was there from the beginning, the facilities were given the instruction to report to CRISP. But what was not given at the time was the how they should be reporting to CRISP. So it took a little bit of time for the facilities to be able to completely understand the reporting requirement. And then when that was done, a week later, the process changed. So many of them got caught just in not understanding all of the components of that reporting. So I just wanted to lay that out there, because I think it's unfortunate often that those facilities who were 100% found to be compliant in the infection control surveys were not actually given that type of credit. So like I said, I think that's an important distinction that has not been made. But going back to kind of where we have been, In the early days of this pandemic, it was March 6th when Maryland identified its first 3 cases, and the nursing homes were locked down and the assisted livings, which was the right decision. We needed to do that, or they needed to do that. But it was a frenzy for months afterwards. And as everyone here on this call has heard, just the procurement of PPE was an insurmountable challenge for these facilities, and the amount of PPE that was needed. These facilities were competing with the federal government, state government, other providers on trying to get the same PPE. Lifespan was actually given a loan from a local physician and was able to pivot for the industry and buy PPE at a bulk rate. And Lifespan did distribute 227,191 items to organizations for PPE. Some were able to get PPE from the state stockpile as well and from their locals, but it was just a small percentage. So I think that was one of the greatest challenges moving forward for these facilities. The other major challenge was staffing. Unfortunately, we had staff who did fall sick, and we had to replace those staff while they were recovering. Other staff had to leave because of childcare issues, and some, it is an unintended consequence, but did leave because of the ability to get unemployment insurance at a higher rate than they were getting in wages. So because of all of those factors, the facilities did have a much higher expense to ensure that they had adequate staffing. Many provided their workers, their direct care workers, with heroes pay, and were able and had to turn to staffing agencies at, again, sometimes at 3-4 times what they were paying pre-COVID. So between the purchases for PPE and the staffing costs, the industries, both assisted living and nursing homes, just had a massive fiscal issue to be dealing with. We also had, for nursing homes and the larger assisted livings of 50 and more, there was a requirement that began probably around mid-June for testing, to start testing. Up until that time, the state did pay for weekly testing, but then it was transferred on August 15th to the nursing homes and large assisted livings to pay for weekly testing of their staff. Now, if a staff member became positive, it also then required that all residents had to be tested. So you can only imagine the cost of that for most facilities, depending on their size and the cost that they could get for the testing. It was an expense of $9,000 to $16,000 a week. And for many individuals, especially the assisted livings, they received no reimbursement from the feds for that cost. Just recently, HHS has been given monies to the assisted living communities for under the Provider Relief Fund, but it has been minimal when you consider the cost. Nursing homes have also been giving money from the Provider Relief Fund. That's the federal under the CARES Act. But again, that has failed to cover the increases that they have paid for. As far as visitation limitations, what I had mentioned earlier is the facilities locked down in early March. And from that time, additional guidance had come out that prohibited indoor visitation, but it also made restrictions on outdoor visitation. And of course, when you consider, the August heat, it was very difficult for many to have outdoor visitation. But what it also did was it required facilities to go through 4 phases. And when there was ever an outbreak, and remember, an outbreak is 1 case, they had to revert back to the beginning. So even when they had made progress on trying to get residents with outdoor visitations, and more importantly, we talk about visitation, but a lot of the limitations also were in activities that could be done within the facility with the residents, communal dining activities. And when there was a case, virtually or basically made the residents go back to their bedrooms for 14 days. So that was a real challenge. And I know that as providers, the providers saw the decline in the residents because of that social isolation. And it was so difficult, not only to not have their loved ones visiting, but not being able to do activities with them as well. So it really is a two-part issue. So that continued on until basically October 1st. So again, just to go back to summarize, the first 6 months of this pandemic have just been extraordinary, with the procuring of PPE, the staffing issues, the limitations on visitation, and the cost of testing. Now, much of that has changed October 1st, when Governor Hogan, Secretary Neal issued new guidance. And that guidance is twofold. It is the weekly testing has been modified. It's why it's still recommended. Facilities can follow CMS guidance. And CMS guidance actually is 3 parts for testing. If your facility is located in a county that has a positivity rate of 5%, you only have to test monthly. If you are in a county that has a positivity rate between 5 and 10%, you have to test weekly, and over 10 is twice a week. Now, that is not based on Maryland's positivity rates. It is based on the feds. They post on a dashboard every 2 weeks where the counties across the country are. I looked at it this morning, and we have only 2 counties who are above 5% right now. That is Caroline and Worcester counties. And they will still be required to do the weekly testing. Now, as far as the testing, there is 2 parts now. As you have been reading, I'm sure, and listening on the news, the feds have been sending point of care tests to the nursing homes and point of test kits. And they are invaluable when you believe that somebody is symptomatic and has an infection. But that is not the only type of testing that has to be used. If you do have a positive, you have to then test, again, all your staff and residents, and it's using the PCR test. That's the nasal swab, much more the molecular test that is much more sensitive. So it is really a 2-part testing process now, using the point of care, which really does help isolate those symptomatic residents more quickly, or staff, and then following it up with the PCR test if there are positives. Now, one of the other set of guidance that came out on October 1st is the loosening of the visitation. And this is again by CMS guidance. And I just wanted to mention a few things here. And it is true, there is relief on the visitation because it is so important to mitigate the social isolation, but it's not without anxiety. It is cost prohibitive, unfortunately. In a perfect world, it wouldn't be, but it is cost prohibitive for these facilities to continue testing on a weekly basis. They just can't continue to afford it. They did it for 8 weeks. So it is trying to develop those protocols that allow residents to see their family members, but also do it in the safest way possible. So one of the things that the guidance did is, of course, it always recommends outdoor visitation over indoor visitation because it's safer. But let's be honest, we're going into the winter, and that's going to be more difficult. So for the indoor visitation, it is allowed if you don't have an outbreak in the last 14 days or you're not going through outbreak testing. So that is one thing that family members have to realize. If there is one case, then they will not be able to visit. But what was really good about that limitation, or not, I'm sorry, that limitation, but that guidance is it did away with the phases. So if you are infection-free after those 14 days, you can continue the visitation, you can have greater communal dining and activities, Before, if you were able to do that, you had to build back to that. So that has done away with that. So the facilities are able to get the residents with masking and social distancing, and I should say when masking when it's feasible, but social distancing, back into activities, back into communal dinings. There has always been a provision for compassionate care, but the guidance did expand on that definition. So it's not just end of life, but it really does expand it more to individuals who may be, more helpful for a family member. For example, I've always heard, the family member or the resident who is having trouble eating, and the family member comes in and assists with that. So it expanded that. It clarified the direct care, other direct care workers, healthcare workers such as hospice and home care, and the need to ensure access to those workers in person. So that guidance really has made a large difference. It went into effect October 1st. I would just ask that all family members allow the opportunity for the nursing homes and the assisted livings to get their policies in place. Because one other issue that this guidance did recommend is, we're not just throwing open the doors and saying, come on in. It has to be controlled. So CMS recommends that visitations be scheduled, the number of individuals who are visiting be limited. You cannot, unless there's a specific reason, go into a shared residence room. So there has to be a visitation area indoors. So there's a lot of work that has to be done to make sure that these visits can be done safely with all resident and healthcare workers in mind. Now, as we move forward, where do we go from here? And I think that there's a few issues, and Eric did raise these, but it has been said that these facilities were ground zero, and that is absolutely true. And what these operators, and especially the healthcare workers, need right now is stability. They have been dealing with so much guidance that comes out of CMS and the health departments and the locals. And I will say, I'm an attorney, I read this guidance, and I'm always confused on what some of it may say. Especially with the CMS, it's called guidance, but sometimes it says recommendation, sometimes it says required, sometimes it says should. So it's very confusing and very conflicting. So they have been dealing with putting in their protocols and making sure that they are in compliant. And that goes the same for reporting requirements. They're reporting to CRIS, they're reporting to the local health departments, they're reporting to the feds. It does get very, very confusing. But for the stability, that's also the financial stability. So many of these facilities have just expended just an unimaginable and unbudgeted amount of money on controlling this pandemic. And at this point, there's really no end in sight for it. So those expenses are going to continue. We have to prioritize. It is not lost that the state is going to have a major fiscal deficit, but cutting or reducing the base rates to these facilities is not going to help quality of care. And that goes to the 4% mandated rate increase. That 4% mandated rate increase was part of the minimum wage. The minimum wage is still going up. So that 4%, we're going to ask that if it is brought back as part of a BRFA, that you please reject it. And for the budget committees, please ensure as much as you can that these facilities are given priority for funding so that they can continue to purchase what they need to purchase, pay their direct care workers, and go forward with quality. Now, one of the other issues that came up, and it's 100% correct, is the direct care workforce. There was a crisis in direct care workforce prior to this pandemic. It has been worsened by this pandemic. We need to have new recruiting strategies, and we need to have individuals who want to go into this line of work. I know, speaking for Lifespan, we have developed a CNA GNA online training that we have ready to go, but we are waiting for state approval or the next steps from the state. I would encourage any help we can get because that is needed now. There are so many individuals whose jobs, unfortunately, will just not come back from this pandemic in hospitality and other sectors. And we should be looking at ways that we can transition those individuals into these jobs. And that also goes to our graduates who may not be able to go to college right away or may not be able to find jobs to transition to this important area. And I think we do have the tools already. We have the Department of Labor and we have the Governor's Workforce Investment Board. I think we have to empower and prioritize the programs that currently exist that they're working on and new programs to be a priority. But I definitely would agree that workforce development is probably the most single important issue facing the industry as a whole. And in conclusion, the last point I'm going to make really is the vision for long-term care services. When I was listening to the speakers from AARP, they raised the issue that Maryland is in the third quartile for a choice of setting and provider. And I'm afraid that that's going to get worse because over the next year, with the economic realities of the costs that these facilities are undergoing, I think you're going to see, especially the smaller providers, but all providers, really seeing if they are going to be able to continue operations. And for the small providers, whether or not they're going to end up closing or worse, going underground. So I think that that is a real concern. While you asked me to talk about assisted living and nursing homes, I am just going to say one thing. Medical adult daycare centers, which is a major home and community-based services that allow individuals to stay at home but still get needed medical care, they have been closed since March 17th. And those providers, luckily the health department did provide an administrative rate to those providers. But we have to consider how much longer those providers can continue to stay in operation so that when they are allowed to reopen, they are there. So again, I think that the major issue is just stabilizing senior care services. So in the next year or two, all options are there for Maryland residents. So I will conclude with that comment and I welcome any questions.
Thank you, Dana. I know we have a question from Senator King.
Thank you. I don't have the answer to this, and I'm guessing you don't either, but what I see here in my community and really Montgomery County is what my point of reference, but the caregivers at these nursing homes and extended care places have at least like 3 jobs. They don't make much money in one place. So they go to wherever they're needed, and thank God they can do that because they slip into places where there isn't enough care. But then you don't know where they've been exposed or who they've exposed, and it puts all of them in a really bad position. Also, if they made more money, they could probably work 8 hours and go home, but they don't. So that's what they're doing, is kind of filling in to more than one place.
Right, and that was a major issue early on, that you had direct care workers, as you said, working in 3 or 4 different facilities or communities. And unfortunately, there were some facilities that basically had to say, you need to choose one because, the lack of a better term, the cross-pollination is just simply, you're exposed too much. Now, I will say for wages, I think it's about 67% of nursing home residents are on Medicaid. So that is always been,
I bet at least that.
Yeah, at least that. I'm probably being low. But that's always been a challenge. I mean, we have the now the $15 minimum wage phase in, which luckily the General Assembly gave the 4% to try to cover that cost. But any increases in direct care wages is going to have an effect on the Medicaid budget. So it's really that catch-22.
And Senator, I just add to emphasize your point, and I think this has been articulated, it really reiterates the need to figure out a path forward on testing, especially as we prepare for the second pandemic. I know in my home, I don't want anyone coming into my house, not my parents, not my family and other family members. And at long-term care facilities, the staff is going in and out of facilities daily. And from what we've heard from what the Trump administration CMS guidance says is that in Montgomery County, testing is now going to take place monthly. So it's a reason why we need to continue providing subsidies for this industry. It's a reason why we need to look to the 500,000 rapid point of care tests that the governor negotiated. It's a reason why we need a next stimulus package to help this. I just testing, because this, in alongside that, as I mentioned, caring for the mental health of this staff that is under just tremendous stress during this pandemic.
Okay, and we do have a question from Senator Washington.
All right, thank you. First of all, thank you, Eric and Dana. Thank you so much. Both of your presentations, I think, complement, coming from different perspectives, but you're saying the same thing. And I think we hear you about our staff, about testing. I wanted to, and that I agree about the crisis and direct care workers. I wanted to, I guess, ask you, and I guess I should, maybe this is Dana, what with regarding what type you're asked for consistency, right, and stabilization. So when it comes to these recent orders, would it be helpful, or do you have a sense of, what kinds of things most of your providers would like to see when it comes to opening up? And then also combined with like Eric. In other words, it seems to me it might be reasonable. Again, I have a personal interest. My mom is in long-term care. We see her doing Zoom calls. We've been able to do the outside visitation. However, I would certainly be willing to demonstrate that I'm COVID-free before I'm allowed to go in. Is the state able to make it, if a facility wanted to require this, would they be able to do that? And what would they need? What type of authority would they need to be able to require that someone be COVID-free, for example, before they're allowed to come indoors for a visit?
If I can answer that, good question. The CMS guidance that was adopted by the health department does specifically say that facilities may also encourage visitors to be tested, but it is not required. So far, I have not heard of facilities requiring that yet, but that is a good question. I mean, this guidance was just issued last week, so I think that the facilities are still trying to implement it as best that they can. Now, I know that their testing policies have to be sent to the Maryland Health Department for approval, or for at least review. So I think that is a good question, but I also, I don't have the answer for you just yet. The CMS guidance says, encouraged, or facilities may encourage, but it's not required. So that, that always puts the facilities in a little bit of a catch-22.
Right, and I want to take that off. I mean, I don't want you to have to deal with people being frustrated, but it was ground zero. We've made a tremendous progress. We've reduced it. I mean, we just don't see the infection rates that we saw in March and April, and we just don't want that to go back, right? And so how do we as Marylanders, and how could this committee, I guess, and please let us know, how can this committee immediately support and work with the administration to come up with policies that are focused on protecting Marylanders, caregivers, staff, as well as our residents.
And I think a lot of it also depends on the situation of the facility. For example, up in Western Maryland, I think it's Garrett County, their positivity rate is less than 1% right now. And there are facilities who have had no resident infections. So I really think it's trying to create that balance. And we also, we want to encourage family visits and not discourage or have anyone come and be very mad. So it's a balance, but I think it's something that we have to keep an eye on over the next few weeks, because like you, the last thing we want to do is start seeing spikes in the nursing homes because of the vulnerability of the resident population.
And we saw those when we opened up the bars, there was a spike and then it came back down when we opened it. I mean, we just see this. So I would hope that we would learn from past experience that we need to be very careful. And then just finally, I just want to put it out there that I do agree that it could be, I guess what I'm looking to do is to empower each facility to be able to make that determination, right? To be able to say, no, this is our policy because of our risk factors, or this is our policy because we don't have the risk factors. And that we require a negative test, or we require that it's just one person. Because right now it's, if I pushed, I could just go in there right now. I could be COVID positive and I could potentially infect other people. And I don't think I should, even as a family member, have that right to expose other.
Now, I will say too, is that each visitor is subject to screenings, but also for PPE requirements. So, the screening is always, there's a lot of issues that people have with the screenings, when you answer the questions, you don't have a fever, things like that. But we all know that there could be, asymptomatic positives. But they are also required to wear PPE, as are their residents, and practice social distancing. So those are non-negotiable. So hopefully that will help control spikes as well.
And then I guess I lied. The last thing is I love the idea about transitioning some of the other workers that are doing other things. I've actually seen that in my mother's facility, that people who were doing other things are now doing recreation and they're doing some other things. And for us to figure out how to invest in that existing workforce through training and supports. And maybe that's some ways that we could provide some grants or supports for you all to make those types of transitions. So again, thank you both very much. Eric, I want a copy of your very well written speech. If you could share that with the committee, I think I'd appreciate it. Thank you, Madam Chair, and I appreciate you giving me that personal privilege since it's such a close issue that's so close to home.
Obviously, you care a lot about it. There's one more question in the chat from Senator Hedelman, which I think is also for Dana. Do facilities actually have use of the rapid tests yet?
The rapid test, I can't say that every facility has access to them yet. They have been delivered. I think the majority of the facilities have the rapid test. Some are still waiting. In order to use a rapid test, you have to have a CLIA waiver from OHCQ. So some are still working through that process. I do know that they're being used because I've also heard that there has been issues in trying to get additional test kits for those rapid tests as well. So we're going to continue to work with the health department on some of those supply issues. I know that we have a call tomorrow with the health department on the testing issues, since the governor did announce the additional $6 million for testing services.
And I would just add on that, while the state in its most recent guidance really punted to CMS, beyond that, they did issue some directives with regard to rapid point of care testing. And I think we're seeing that becoming, despite the fact that a nasal swab test is required after that. And we're seeing the normalization of rapid point of care testing, when we're also seeing the lowering of cost over time of this testing, which I think is really beneficial. It does nobody any good, not family members, not individuals, not facilities. If someone comes in and they had a test from a week ago, or the idea of knowing their status instantly, really, to the best of our knowledge, is a factor and an important one in controlling the spread of this pandemic.
Well, thank you. Thank you for that. One last chance for any more questions on this panel. We have half an hour left to deal with the update on services for individuals with developmental disabilities. So perfect. Thank you so much to both of you for sharing all this information with us and for the work that you have been doing. And particularly, Dana, please pass on our appreciation and gratitude to the entire workforce that you're working with. We know it's been a really challenging time for them, and we appreciate their work.
Thank you.
Let us hear from Bernard Simmons, who is the Deputy Secretary of the DDA, and then we will hear from Laura Howell and Sean Cross. Sorry.
Thank you, Chair Kelly and Chair Washington and members of the committee. I'm Bernie Simons. I'm the Deputy Secretary for Developmental Disabilities in the Department of Health. We obviously will take the opportunity today to take a look at and update you on where we've been since beginning of March. Next slide, please. So we worked with all of our state partners and stakeholders. We were very concerned when obviously the pandemic started, and a lot of our providers within the state closed their day services. And so we have about 18,000 people among the 3 home and community-based service waivers that we have, the largest being Community Pathways. And we have people who are in residential services, about 6,500. And so obviously people wanted to stay at home. And so people did stay at home, either with family members or with providers. I think it did, as I heard earlier in some of the conversations in the presentations today, basically stressed a lot of people. Obviously, it stresses everybody with this COVID. We were concerned about getting enough updates out to everybody, so we created a COVID-19 webpage with resources and guidance that was coming in from CMS and the Center for Disease Control. We actually then developed some toolkits, guidance, screening tools, and checklists. We were very fortunate to have the staff from the Center for Disease Control, Dr. Kenneth Fetter, who works for them, who's assigned to the department, engage with us in a DDA and to be able to help us develop some of these screening tools that were obviously put on the web and working with our providers in the community. We also had the opportunity to work with Medicaid, and there is something called Appendix K, which is what the Center for Medicare and Medicaid Services allowed the states to relax the way that they were delivering services. So as an example, if you had a service that you were receiving face-to-face, that you could receive this remotely. I was concerned that we basically, complete these forms submitted to the feds, but I was really concerned about having what guidance would look like. So we actually operationalized so that it was hopefully clear to everybody, and we got some positive feedback about that, so that people would know, what does this Appendix K mean for me, and what does it mean, day to day when the operations of my agency. Next slide, please. So we had an opportunity, and I'll talk about this about PPE in a couple of slides, but we've had the opportunity from the state stockpile to distribute 5 different rounds of PPE, over 225,000 pieces to provider agencies, individuals who are self-directing, and microboards. Those deliveries have gone to all of our 4 regional offices, Hagerstown, Salisbury, Laurel, and Baltimore City. And we've notified providers when all of those supplies are available. So that was one thing we did. We did also, through Appendix K, have something called provider retainer payments, and I do have a slide coming up on that. And what a retainer payment is what you would pay for services that were not delivered. And that was allowed in that Appendix K. And so we were concerned that, providers still needed to have income. Even though the day programs were shut down, some of the providers did furlough staff. Some of the provider agencies did lay staff off, and some reduced their hours. So of the 200 plus providers that we have, they obviously worked with, as an executive director, worked with their board of directors and came up with some of the policies, what they wanted to do within their agencies. As I said earlier, we get about 18,000 people in the waiver in supports. 6,500, we obviously can know where they are because 24/7 they were with their residential provider. We were concerned about what were people doing when they were at home with their family. So we actually created a wellness check and had our case management go out and do visits and calls. And it was more calls than visits, then obviously, because everybody wanted to stay socially distanced. So we had those check-ins to know what was the status of individuals and how they were doing at home with their family members. We posted updates on our website so that there was a provider relief fund through CARES. And we actually, on July 15th, there was the Nonprofit Recovery Initiative Fund, and I've got a slide on that, and I'll talk about that in a second. Next slide, please. So what is the Maryland Not-for-Profit Recovery? So we had heard from the providers that before we had the ability to do the distribution on the 5 deliveries that we had from PPE, that agencies were going out and they were actually purchasing PPE on their own. Obviously, that was out of pocket. So we had worked with the Department of Disability, Secretary Beatty, and with obviously behavioral health within Department of Health and us at DDA, and actually worked with the Department of Housing and Community Development, and had money carved out specifically for the BHA and the DDA providers. Initially, it was like the awards were up to $50,000. We found that some of the requests that were coming in were more than that, so we upped it to $75,000. And initially, it was for cleaning supplies and for PPE for reimbursement. We found that obviously that there was some additional concerns that the cost of this public health emergency above and beyond could be food, could be other areas. So we opened it up to more than just PPE and cleaning supplies. So far, there's been 142 applications. Again, that's $8.2 million that's been requested against the $10 million. It's still open. And it's been 80 DDA providers have submitted applications for that. Next slide, please. So we asked for a lot of flexibility from the federal government in the Appendix K for all 3 waivers that we have. And obviously, that is good, the Appendix K until March of 2021. Some of these include remote services, retainer days, increase in respite service hours, additional funding for some group homes, and We streamlined the approval process for anybody who is either changing their services because life still goes on for folks and what they may want different services than what they're currently getting. I can say that I think some of the providers became extremely creative. People who were receiving day services that were living with a different provider who was responsible for the residential services, they jointly worked together, and some of these day providers actually purchased laptops so that their staff, who they didn't want to lay off, could still interact with people remotely. So this remote service was, I think, something that if we didn't have the pandemic, probably would not have explored as much as we did. And we have a lot of people who really don't want to go back to face-to-face services and really want to stay with remote services. We initially had retainer days, and those retainer days were basically looking at 18 days. Retainer days are basically tied to the number of nursing home bed hold days which is 18. And we get a lot of feedback from our providers that obviously they were concerned about 18 days wasn't sufficient, and they really wanted more than that. So we went back, as you can see, to CMS, and they approved us going to 30 days versus 18 days. And they also we got approval to do personal supports in hospitalizations. And there's been a joint memo from Secretary Neal and Secretary Beatty that is going out because many individuals who are in hospitals would need additional assistance. And obviously that's something that everybody was concerned about in order to meet the needs of people with intellectual and developmental disabilities. Next slide, please. So retainer days are allowed when the providers are unable to provide the services. As I said, it went from 18 back to 30. And in addition to residential, the Appendix K allowed us to pay for day services when people were not there in supports and services. There's been some discussion about what is day services, what does this mean for an Appendix K, and what does consecutive days actually mean? I can tell you that we reached out through Medicaid at the beginning of this week and received an email back from CMS that basically says you need to think about retainer days as billable days. So if you were having a service that was defined as day habilitation Monday through Friday, then the weekends would not count. So day 6 then would be the following Monday. So those are straight days that we would use. So it's really consecutive billing days. So if you're in residential, you could go 30 days. If you went 10 days and then stopped, then you can't pick up and go 11, a month later and or whatever. Excuse me. Next slide, please. So we have been doing waiver amendments for the past few years. We're on Amendment 3. And the things that we learned in Appendix K about remote, and as I said earlier, people basically wanting to say, I want to do remote. I don't want to go back and do things face-to-face. I enjoy this. We are adding all of those services to the waiver. That was posted on September 1. It closed September 30th. And we're in the process in DDA of cataloging by topic all of the recommendations for the open comment period that we had to meet the regulations of CMS. Next slide, please. So DDA has 2 state residential centers, Holly and Salisbury, and Potomac and Hagerstown. And, you know, I'm really appreciative of all of the good work that all the staff have done at both of the facilities, because we had no residents at either facility test positive. None. I think that's outstanding, especially knowing that staff go home, may work at the Holly or Potomac, may have a job someplace else. And, you know, as we heard earlier about people working in multiple places, you know, obviously there's the potential for exposure to COVID-19. We actually now test all staff monthly. And we mandatory a mask for staff. If somebody is either admitted, and we still admit people to the facilities, then they've got to be tested ahead of time before they come in. If somebody goes off grounds for treatment to the hospital or is admitted and comes back for whatever reason, then we do COVID testing and we isolate in a separate part of the facility. You can also see, instead of sending people out, we've brought in x-ray machines and podiatry, etc. Next slide. So visitation, what does that look like? At the facilities, we don't have any, at Holly and Potomac, there's no visitation yet. However, each provider, depending upon where they are within the state, and, you know, if you look at some of the data that our department puts out, and the infection rates, you can see that initially in Baltimore area and in the capital region area were the highest numbers of people testing positive in the general population. And also that was reflective in our DDA population, specifically looking at Prince George's and Montgomery County. So if you looked at the percentages in the East Shore and in the Western region, obviously they were a lot lower. I think it was 1% in the West region. And so obviously being spread out a little bit more, we've asked the providers to take a look at, you know, if you are thinking about reopening, what would you do? And it's basically done region by region. It can't be done statewide, only because of the dynamics of, if you were down in the you know, capital again, there's a lot of public transportation that we don't necessarily have on the East Shore or in Western Maryland. And so again, we worked hard with the Department of Disabilities and our stakeholders to say, what does this look like? We revised our guidance on visitation and everything we've done, specifically around, as I mentioned earlier, with Secretary Neal and Secretary Beatty in visiting hospitals. Next slide, please. So we actually created a web page for COVID with the toolkits that I mentioned in the first slide. We've got an Appendix K with the federal approval and those operationalized what we've done. I can tell you, starting in March until probably about mid-July, I did a webinar every Friday from 1 to 2. And it had multiple people present. As I mentioned, we had some providers present about what their experiences were. We had families talk about their experience. And that was at the end, towards the mid-July. Early on, we basically had our experts, epidemiologists, as I mentioned, Dr. Fetter. We had nurses from the department who basically were doing instructions about how to wear PPE, when to wear PPE, etc. And so we pushed out as much guidance as we could, recognizing that, you know, DDA is about intellectual and developmental disabilities, and we're not, you know, the experts on epidemiology. So we, at least within the department, had the ability to work with Dr. Fetter to help create screening tools, etc. There was issues in June about people who would be aging out, the transition and youth group. And so we met with Medicaid and MSDE and issued guidance about those people being able to stay in the autism waiver or whatever they were in and be able to transition at a later date, because we didn't want somebody to be knocked out of their current services before they could get into DDA. I mean, we need to be really sensitive to families who had kids home who were either getting school remotely, as Delegate Kelly talked about earlier with her 4 kids, and doing homeschooling, et cetera. And then again, we offered in August some framework on how to reopen. And it was again, it was only framework. It really wasn't guidance. We found at least 2. One was the National Academy for Developmental Physicians and Dentistry did a very good document about what to consider if you were going to relax, what to take a look at, et cetera. And then there's another association called the National Association of State Developmental Disabilities Directors that also put out some guidance and had a lot of information from a lot of states. Many states do have medical directors on their staff within the DD administration. Next slide, please.
Deputy Secretary, let me just interrupt you for a second to give the committee a time check because we have 2 more presenters after this and we have 11 minutes left. So
okay.
To wrap it up, I want to make sure we have time to hear from Laura and Sean.
Okay, so basically, this is, and obviously I don't need to go through this, but this is just a sample of what we did, like in April 10th, training on the PPE, as I mentioned earlier, April 17th, outbreaks for home, preventing outbreaks. Those are just the topics that we covered. And then family perspective of our son, et cetera. And then we did one on Amendment 3. So we did those weekly webinars from March until July, and then we do every other week now. And we actually ask people for what additional topics, because life still goes on. I mean, everybody's really concerned about PPE, COVID, exposure, et cetera, but there are still some other things that people want to talk about re-engaging, getting the community. Next slide, please. These are just resources that we have on our website, what's on the website, et cetera. Next slide. Again, more guidance, et cetera. And then the last slide should be more guidance. And that's the end of my presentation. And thank you again for the opportunity.
Sorry to rush you through the end, and thank you for
okay.
such a great presentation for us. So we'll make sure to follow up, look at those links that you shared. Laura, do you want to go ahead and jump right in?
I'm going to go ahead and start. I'm Sean Cross, and for the sake of time, Laura is going to just stop her initial comments and finish with at the end. So I'm Sean Cross. I am the CEO at the ARC Northern Chesapeake region, and we provide services and supports to about 400 adults in Harford and Cecil County. And, as everybody was talking, mid-March was really when everybody had to turn on a dime. And I'm just going to quickly kind of go over our personnel issues. It was huge for the developmental disability providers, especially the fear that took place in the spring, made maintaining staff a real challenge. We as a provider were somewhat lucky because we were able to deploy many of our day team members to our residential, which then became 24/7 sites. We still had a shortage though because of either health issues or childcare issues that our day team members were facing. The guidelines, during that time weren't always clear or timely. So we were always reacting to the new information that was being posted by the CDC and making our decisions, from this material. In the beginning, we had people we support who tested positive. And at that time, it was almost impossible to find team members who would work in the home. Fortunately, that has shifted over time, and we were always able to find team members who were able to support the people in the residential home. We spent a lot of time educating our direct support frontline workers about wearing PPE and the off-hour risk. As mentioned by previous presenters, that we shared team members with nursing homes as well as other DD providers. We had many DSPs who have their own health issues that put them at risk, or had family members that put them at risk if they were returning home. Many of our frontline team members are single parents, and they are struggling with the ability to work and support their children's remote learning. Low-wage workers made more on enhanced unemployment, unfortunately, which created a difficult dynamic when staff were laid off, and then the staff continuing to work. And as we start to reopen, there's all types of things that we're looking at as far as, what's open in the community, transportation, how do you do that safely? And as weather issues, as people have mentioned, outdoor activities are difficult. And then I want to just address some of our family issues. Most of our families lost the daytime supports for their adult children. And this includes many older parents who are now 24/7 caregivers, and some face physical and emotional challenges as a result. And these parents could not utilize childcare that was provided to young children for essential workers. They lost access to respite, and that all added to the stress. And, there continue to be educational issues. We support about 300 families in addition to those 400 adults that have children who are school-age children. And we get numerous calls and concerns about what's happening with the educational system and implementation of the IEPs. Visitation policies. Our initial visitation policy was very strict, and those have really, each provider is making their own decision, as with everything they're doing, depending on kind of what's happening in their community. And it's very challenging to move forward based on the different risk factors. And we are just basically making those decisions based on age, underlying health conditions, ability to physically distance, wear masks, all of that. One thing I think is important to know is that at our agency, we had over 90 people who were working, people we support with developmental disabilities who are working in the workforce. And when COVID hit, we continued to support over 30 people that were considered essential employees. And we're back up to 60, so jobs are returning, but it has had a huge impact on the workforce. But also, I think it's important to say that the people we support were considered essential and very needed during the pandemic. We did offer remote support, and that worked for some people really well, others not so much so. And as we continue to look forward to what some of the constraints are and what our abilities are, I think weather is going to have a big factor. I'm going to turn it over to Laura now. Thank you very much.
Thank you.
Thank you, Madam Chairs, members of the committee. I'm Laura Howell, the Executive Director of the Maryland Association of Community Services. We represent about 100 organizations that provide community supports to people with developmental disabilities. And I'm going to basically cut most of what I was going to say for time and say a couple of things, and then touch on an important policy issue. The federal funds that have come through and the flexibility that has been provided through some of the work of the Developmental Disabilities Administration and the Department of Disabilities have absolutely made it possible for us to continue to operate under unbelievably difficult circumstances. And so we are absolutely appreciative for that. The issue I want to touch on is the issue that you heard Deputy Secretary Simon speak about, which is this issue of retainer days. And I know it sounds kind of weedy, but this is a really critical issue because before COVID hit, we actually had 30 days. And, our system is really underfunded. And so any loss is significant. And it would take more time to explain it than we have. But a number of states got caught up in an issue when they submitted their Appendix Ks, and as a result, had to make changes. And what happened in Maryland is we went from 30 days of being able to be paid when someone was in a hospital or a nursing facility or with their family, to only having, we have 30 days during COVID, but when we come out of COVID, we will drop to 18. And that is a huge issue for us. It is a huge issue for people who use supports. The other piece is that there is an issue that relates to the interpretation of what we're all being collectively told by the federal government. We believe that the Department of Health has more flexibility under the federal guidelines. We're currently in communication with DDA and the department about it, but this is an ongoing issue. And from a policy standpoint, the two recommendations that we have are that the 30 days be reinstated, which the department can do, after we come out of Appendix K and COVID, and the issue that Ms. Kaufman spoke about, which is that 4% increase. When you all look at the budget, the need for better wages for DSPs is really critical. It's not only because they do incredible work, but we also see now, because they're working so many jobs, that it is a health risk of going from different, home to home and facility to facility. So we strongly recommend that you make sure that that funding stays in the budget.
Thank you. And I'm sorry you had to consolidate your remarks. We can stay on a couple minutes over for questions. I know we have a question from Senator Sidner. If members need to leave at 12 on the dot, please feel free to check out. But Senator Sidner, go ahead.
Thank you very much. This question was actually for the Department of Health. And it's two questions. One, on page 4 of your slide, you had mentioned the Maryland Nonprofit Recovery Initiative, and I was wondering how that information about that program went out to providers, number one. And the second question, and your department had been somewhat helpful in this, but I have been receiving communications from some providers about issues that they've had with, I believe the company's name is Optum Health, and the attempt to get certain reimbursements and payments from them. And I was wondering if there was any update on how Optum is now doing with the behavioral health providers that are out there.
So this is Bernie Simons. So number one, for the reimbursement money for the NORI that you would request, we had put that out in an email blast. We have something called Constant Contact. And so we put it out, and so did the Behavioral Health Administration. So they sent it out to all of their providers also. So when the slide showed about, we had 143 and 80 were from DDA, obviously the Delta was the behavioral health providers. As far as Optum, I can't really answer that question. I don't use Optum. We pay directly to DDA providers on a prospective payment. So as an example, on July 2nd, we pay the providers 4 months in advance so that they have the cash flow. And then in the next quarter in October, we pay 3 months in advance. So that's the way we work. So Optum is more about behavioral health than, so it's out of my realm.
No problem. Thank you.
Okay, any more questions? I'm not seeing any other questions. Senator Washington, did you have any closing remarks you wanted to add for the committee?
Just thank you all so very much. We look forward to working with you, and again, all of our frontline workers, hospital workers, daycare, everyone's doing a tremendous job. We so greatly appreciate it.
And I'll just close by adding that we will meet again in November for our last meeting of the interim, and that will be discussing childcare. Thank you to everybody.